Hello, welcome. Good morning, good afternoon, good evening to wherever you're tuning in from. Welcome to our Facebook Live Neurology webinar session. Today is our end of summer neurosurgery special. So get ready for cooler weather. A bit odd to say that to people in England, but apparently it's pretty hot. So today's session is sponsored by Fusion Implants, and this is part of a wider research project that also included a Fusion Implants sponsored PhD in collaboration with our speaker today, Colin Driver, and Jeremy Rose, and the team at Lumbury Park, as well as researchers, clinicians from the University of Liverpool, and has spanned over the last 7 years. Further information about our sponsors, Fusion Implants, will come up at the end of this session. But for now, we're pleased to welcome Dr. Colin Driver. Thanks very much, Colin, for giving up your time and spending this evening with us, telling us about your study. Colin graduated from the Royal Vet College in London, completed his neurology residency at the Royal Veterinary College, and achieved diplomat status in 2012. He has a PhD studying the pathogenesis of canine syringomyelia. He has worked at the Royal Vet College and in private referral practice in the south of England for just over 10 years, and became a fellow of the Royal College of Veterinary Surgeons by meritorious contribution to clinical practice in 2022. Currently, Colin is at Lumbury Park Vet Specialists in the UK. And today he's going to discuss the study, which has been recently published, entitled, it's quite a long title, so Instrumented Cervical Fusion Using Patient-Specific End Plate Conforming Interbody Devices with a Microporous Structure for Dogs with Disc-Associated Cervical Spondylomyelopathy. So thank you very much again, Colin, for coming on and sharing your experience in this publication with us. I'm going to hand over to you now to take it away.
Thanks, Simon. It's actually pronounced Driver, my surname.
Once I had a chance of getting the surname right.
Not really. Once. No, it's definitely Driver, as in bus. Yeah, thank you for having me. Thank you for the opportunity to speak about our project. I think hopefully we won't get interrupted by any of my 6-year-olds running around, but if we do, hopefully, hopefully they'll just be out of the way. So yeah, I think we can. Are the slides loaded up there? They're on. Okay. Well, that's up to me. Presentation, and then we're away. Okay, great. Yeah, so bit of a mouthful of a presentation, really. A bit of a mouthful of a title for this study. Obviously we're looking for an award for the most long and convoluted title of a study ever, but. Yeah, so here we're presenting a recent paper that's an open access publication in Frontiers. So if you haven't done so already, please feel free to read it. Yeah, so this is a treatment technique that we've developed and utilized in a number of dogs now with disc-associated cervical spondylomyelopathy or wobbler syndrome, as we very often end up calling it. Just by way of introduction, I've got a few points here for discussion that I thought would be interesting to give some background as to how we ended up sort of conceiving of this implant or device, and some of the thoughts around how we managed to utilize it successfully, and then just to dive into an overview of the publication, so talk about how we actually constructed the study and what sort of data we were actually looking at and recording, and the outcomes that we had, and then a couple of long videos by way of case presentations that should hopefully generate some interest as well. So talking in depth about the etiopathogenesis of wobbler syndrome is probably outside of the scope of the presentation, but typically when we consider this a surgical disease, or at least surgical outcomes are considered generally to be better than medical outcomes, although a direct comparison has never really taken place. We believe patients have a better outcome with surgery. And the disease seems to be related to recurrent compression or recurrent vascular compromise of the spinal cord and nerve roots in the predominantly caudal cervical region, which acts as a fulcrum of the crane, with the supporting the heavy weight of the skull. And the biomechanics of this area are particularly complex. There's large degrees of rotational forces as well as axial compression on the disc. So when we treat it surgically, we can aim to either directly or indirectly decompress the spinal cord. What I mean by that is, with the direct compression, we're actually going to remove the part that's compressive. So we can do that typically via ventral slot decompression. And of the two sets of images that we've got on the slide here on the left of the screen, is a patient that you might think would be typically a better candidate for a direct decompression, as a ventral slot procedure might be successful in removing some of that protrusive annulus. And then on the right, though, we can see here we've got a patient where perhaps removing the annulus is not going to necessarily deal with the significant intraparenchymal lesion that we have. And that's where the concept of indirect decompression is considered, which is to decompress the spinal cord by removing the compressive elements, by stretching them out, by effectively taking them away, so without actually directly entering into the epidural space of the vertebral canal. And clearly that's going to be beneficial, particularly where there's suspected to be a strong dynamic component to the disease, which is often the case here. So these patients with these diseases often suffer worsening spinal cord compression in some degree of flexion or extension, and that can be partially ameliorated by vertebral traction. So as a blanket approach to these chronic progressive presentations, we would favor indirect decompression. And the main reason for me is the immediate post-operative effect. So if we were to perform a ventral slot on a chronic progressive case, we may well get a good medium or long-term outcome, but we often see a worsening of clinical signs, and that can be moderate or sometimes quite severe, and patients can be non-ambulant for several weeks with the condition. So that is the leading benefit, in my view, of indirect decompression. These patients can walk out of the hospital 48 hours later, typically without any worsening of their clinical signs. Whether or not the medium or long-term outcome varies is something that we obviously never directly compare, so it's hard to comment on. But there's some clear advantages to this indirect approach, and there have been many surgical techniques described over the years about how to achieve that I can go through soon. And the other thing is this concept of distraction. So love this diagram, love this figure from this study back in the early noughties that Jacques wrote, where we are applying some weight to the front end of the dog and thus able to distract the vertebrae. And as this is proven in these MRI images, that these chronic fibroid disc protrusions or cervical spondylomyelopathy cases will have a restoration of the normal height of the vertebral canal with that distraction, and that ultimately is that goal of indirect spinal cord decompression. So this is a kind of classic algorithm for choice of surgical technique, if you like. I've added a little bit extra some thoughts of mine, but if we're dealing with disc extrusion, we'll most often go for simple direct decompressive procedure like a ventral slot. If we have an annular protrusion, we can utilize these traction views, and either if traction doesn't make a difference, we can consider a ventral slot. If it does, we can consider a distraction fusion technique to achieve indirect decompression. And then this is a little bit I've added on for my own thoughts, which is about whether the other compressive elements like the interarcuate ligament are made worse in extension. Because if they are, I would think that would be advantageous over a disc replacement, or a disc arthroplasty is the appropriate term for that. So this is one potential algorithm for that, but I suppose this is the more simplified and more common algorithm that would apply in our clinic, which is that if we have a chronic ambulatory presentation in a patient, we would most often go for a cervical distraction fusion. Whereas in some instances with acute severe presentations, so animals that have become non-ambulant over the 24 hours prior to presentation, we're often finding that they have an edematous and torn annulus that sort of scrolls up in the epidural space to cause acute cord compression, almost a sort of acute on chronic type presentation. And those patients can still do very well with a ventral slot decompression. And as you can see, I don't favor disc replacement. And I think one of the issues with that is that in dogs, the biomechanics of the caudal cervical region is very complicated. And where these are more successful in people, they're aiming just to resist force in one plane or one direction, which is axial compression, as opposed to excessive rotation, which is what we have in our canine patients. And I was also at a conference recently, it was ECVS this year, where there was a human surgeon, or a surgeon for humans, I should say, who commented that a disc replacement in people he views as a staged fusion, because fusion is so often the eventual outcome of those types of procedures. So in terms of utilizing something to provide distraction and indirectly decompress the cord, this isn't necessarily a new thing. It's been a consideration for human patients for decades, and I just wanted to highlight this case where a human spine surgeon, George Bagby, in the early noughties attended this horse patient, this equine patient, a thoroughbred racehorse called Seattle Slew, who was suffering from wobbler syndrome. And he sort of reverse engineered a human bone graft basket that was being used in people primarily for lumbar spinal fusions, and obviously placed that alongside the vets who were working at Washington State University at the time, and had a successful outcome with this patient. So using some intervertebral device to successfully distract and fuse vertebrae in our animal patients is not necessarily a new innovation. And of course, there have been several attempts at this, and there have been several successful reports of distraction fusion procedures in canine patients over the years. And I'm just highlighting a few here. And with the first author in the year of publication, the full publication list is probably referenced in our paper, of course, but here and obviously probably plenty of these missed out as well. So sorry to anyone whose publications we've missed out, but just to highlight that right from the late 80s or early 90s with metallic washers and cement plugs, several veterinary surgeons have reported the use of distraction cages, either made of carbon or plastic or metals like titanium, some of these being larger dynamic distractible cages, occasionally traction screws or fixed anchored fusion devices, and typically speaking, we're achieving good results in the majority of patients. Although a recurrent theme in the patients that don't do so well in the publications is a tendency for the vertebrae to slowly sink onto the intervertebral spacer, and we call this subsidence. This will eventually cause a narrowing of the intervertebral disc and a recurrent compression of the nerve roots and a recurrent protrusion of soft tissue elements into the canal, like annular protrusion and hypertrophied facet synovium to actually recompress the cord. And so, logically, we're going to look towards what can we do to have something that's more biomechanically favorable to distribute the stress, to distribute the load that's placed onto these often chronically diseased vertebral end plates. And so we're obviously working towards something that's patient specific, and that is something that would then conform perfectly to the vertebral end plates. And we have a publication at the bottom here where we've utilized a couple of these, a couple of dogs with a integrated locking plate, and that was really the sort of authors taking the first step in those directions. So just on that topic, is it absolutely necessary to fuse the vertebrae? Well, we know that in the analogous human condition, which is cervical spondylitic myelopathy, that rapid fixation and fusion is certainly desirable, because of the fact that reoccurrence of clinical signs is more often associated with a failure to fuse, the formation of a pseudoarthrosis, or excessive subsidence, and those reoccurrences are associated with clinical signs. And as I said, we've seen similar things in canine patients. So as I said, we're really thinking along the lines of, can we make something that's patient specific, that conforms better to vertebral end plates, and thus is more resistant to losing distraction and resulting in subsidence and adverse patient effects. And before I kind of dive into a full description of our study, I just thought I'd give you the background as to how this implant is designed. And it's designed, as Simon mentioned in the introduction, by Fusion Implants, who we've worked with very closely on the design, particularly Victor Lopez, who was a PhD student whose PhD focused on the design and manufacture of these. So we will start out, the design engineers at Fusion will start out by segmenting each vertebra. So in the top left image here, you can see we're using software to mask the bone elements away from the soft tissue, so that we've got a model of the vertebrae that we can either separate or use as a whole model before we start deciding how we're going to distract. Now, some discs become very narrow with these diseases. Sometimes they're close to normal. So what we wanted to do is have a systematic approach to how we would determine distraction. Obviously, the main aim is restoring normal disc height and vertebral canal dimensions. And restoring the disc to normal was certainly one option, but we felt that a degree of supraphysiologic distraction was helpful to further decompress the cord. Now, we didn't want to over-distract, and over-distraction in people is associated with worsened clinical signs, presumably because of traction on nerve roots. And we just wanted to cause a small amount of supraphysiologic distraction. So what we went for was a systematic approach where we took the intervertebral disc heights or widths. I kind of use those terms interchangeably, but the width of the intervertebral disc across all discs in the cervical spine, and then added 10%. Okay, and the space over which we're distracting is essentially guided by the vertebra caudal to the affected disc. So we will position our patients in CT with a degree of cervical hyperextension in the same way that you would position a patient for ventral slot decompression, for example. And then we would take our affected disc and the vertebrae either side and create that distraction along the long axis of the most caudal vertebral body. Now we can take those spaces into different software. So software like Creo-Parametric, for example. So this work is done in Mimics from Materialize and then into Creo-Parametric. And what the engineers do here is they map out the morphology of the vertebral end plate using these individual data points. And that gives you this lovely waveform, as you can see at the top right of the image here. And two of those together allows us then to create a spacer for the intervertebral disc in 3D with perfectly conforming vertebral end plates. We don't make it the entire width of the vertebral end plate. We make it the majority of the width so that we are able to actually insert surgically. And then we have an outer solid portion. These are manufactured in titanium by a process of additive manufacturing. So particular technique is selective laser melting. Certainly, I'm not an engineer, so it's not my area of expertise, but hopefully I'm describing this as well as I can. So, as I said, manufactured by an additive process, initially with this outer solid core, and we added a fin as well here so that the implant can be manipulated. And then within the inner core, we had a central space for cancellous autograft that could be packed into the spacer. And then within the remaining structure of the disc, we have a woven trabeculation of titanium. And this is the strut architecture of this titanium is particularly interesting, and it's something that's worth looking into in the references in our study, because it's a truly random study that perfectly mimics the trabecular bone that we see in live subjects. So that's something that's particularly interesting and unique to this implant. And the good thing, of course, about that micro porous structure is it's going to improve our chances of good osseous integration, providing a scaffold for bony ingrowth and also to support the bone graft adequately. So it's going to promote osseointegration and so on. And also, of course, we can use other, alongside our autograft, we can actually use other products like a demineralized bone matrix putty that we can either mix with our graft and pack into the spacer, or we can actually inject directly into the spacer so that it fills that woven structure and promotes bone production as much as possible. And so in conjunction with an interbody spacer, we know that in human medicine as well, anterior plating is also popular, as anterior plating improves the rate and quality of fusion. And there are several ways of achieving this, and broadly speaking, we can split those into mono or bicortical screw placement. So freehand bicortical implant placement in dogs has been shown to represent a significant risk to the delicate neurovascular structures, nerve root, cord, and of course the vertebral artery that runs in the very large transverse foramen that you can see on these images. Monocortical fixation, however, is safer and arguably quicker, and in some studies has had a similar biomechanical properties to a bicortical pin stabilization, although of course we're leaving the native intervertebral disc in those biomechanical studies. So whether or not they're really representative of the situation after we've placed one of these implants is something that we haven't studied yet. Now I'm very conscious of the fact that there is a lot of force that goes into these intervertebral spaces once we have removed the disc, and that a lot of that is axial compression. The muscles and the ligaments of the vertebral column really want to compress onto our spacer, and therefore things like screw back out and so on are going to be quite common as they slowly subside onto the implant. We want to try and resist that wherever possible. And just some general thoughts about this, because the fact that we know that there's so many rotational forces at play here, and you can see in red here some points that I've made from some other studies. A lot of the large breeds that we operate on have more concave orientation to the facets, which allows greater axial rotation, and arguably locking plate constructs are great because of the fact that you can use them in a monocortical fashion. But it's interesting to kind of consider whether or not bi or tri or even quad cortical instrumentation is going to be advantageous. So could we potentially be using more of the vertebral pedicle than not? And some authors even will consider placing an intervertebral cage a monocortical plate fixation ventrally, and will then approach the spine dorsally to place transarticular implants as well, and that is to counter this excessive rotary forces that we have. And we used a mixture of these in our study. So alongside the intervertebral spaces, we also used traditional processes, in silico planning processes, to make drill guides for bicortical screws to utilize either 3 or 4 cortices of the vertebral pedicle. And here you can see some of the design work that goes into that. And this would either be for the placement of bicortical screws that could be enshrouded in bone cement, or towards the latter part of the study, what we've been doing more commonly these days is to use the pedicle screws, as they're called, because most often in human medicine, of course, they are utilizing the pedicle incorporated with rods as well. So here you can see some of the process that goes behind that, and 3D printing is now a very widely available technique, and it's also patient specific, so it's a fantastic tool to utilize to save time in our surgeries and have more accurate outcomes. So we used a mixture of 3 techniques in the study. We used paired monocortical locking plates, we used screws and bone cement, and we used pedicle screw and rod in only one case in the study. This was based primarily on surgeon preference and implant availability. So some notes on the study design. These were patients that were operated on at our clinic, Lumber Park Veterinary Specialists in Hampshire in the UK, but also with the team at the Small Animal Teaching Hospital at the University of Liverpool. We made the clinical diagnosis on the basis of high-field MRI, looking for the traditional features that are published elsewhere. And we would always perform a preoperative CT at the same time as MRI, with the patient positioned in dorsal recumbency with the cervical spine in a degree of hyperextension. And we would typically take a photograph to register how the patient was positioned, purely as a reference for when we reposition the patient for the surgery. And this was particularly helpful, for example, to use the same trough that the patient is positioned in, and to make sure that we're using the same sandbags or towels that are positioned under the neck, just so we've got a similar or very similar degree of distraction, as obviously the design of the implant is based on that positioning. As a neurologic grading, we use the Texas Spinal Cord Injury Score, so it gives you a score for each limb, which allows for greater variation, which is useful for statistical analysis. We operated these patients, and then we obtained medium-term follow-up. It was actually somewhere between 2 and 8 months. The mean was 3 months. And at that time, we would repeat the Texas Spinal Cord Injury Score, and we would perform a follow-up CT. On that CT scan, we would look for evidence of fusion, as clearly that's the primary purpose of what we're trying to achieve. Now, typically studies looking at surgical outcomes for these diseases will utilize X-ray and X-ray only. And that's because of availability and, of course, cost. But we were very fortunate to have CT in our follow-up patients. And so we utilized that to determine fusion. And we did this by creating a region of interest in some DICOM viewing software, and measuring and comparing Hounsfield units of bone versus soft tissue to determine whether or not there was new bone, both through the central portion of the spacer and ventral to the vertebral bodies. We also utilize a distraction index. Effectively, what that does is measure the distance between the cranial vertebral end plate of the cranial vertebra and the caudal vertebral end plate of the caudal vertebra, to give an overall impression of the position of the vertebrae after we distracted them, and then with time to see whether or not there's any evidence for subsidence. And of course, we recorded minor and major complications, major being need for reoperating, minor being those that were considered subclinical or of no concern. And then long-term follow-up, minimum of 9 months, ranges up to 33 months. And what we did in those was either an in-person clinical examination, or we would have a video from the owner and interview them on video whilst we were looking at the dog's gait and so on. And that was just categorically categorized as improved, stable, or deteriorated. And in some instances, we were able to attain a long-term CT scan. And where we did, we looked for evidence of either adjacent segment pathology, ASP, or adjacent segment disease. So disease being where the changes are expected to be clinically relevant, and pathology where we're just seeing changes like end plate sclerosis or spondylosis deformans or narrowing of intervertebral discs that would suggest a domino effect. It would suggest that the adjacent segment was abnormal. And adjacent segment disease, of course, being one of the major concerns about fusion procedures or distraction stabilization procedures where movement is not maintained. And we did some basic statistics on this, particularly the continuous qualitative data that we had, like the distraction indices and the neurological scoring. So onto a gory picture, just in case you've got any family in the room, but these were how we would position the patients in the operating room or theatre. And as you can see, the degree of hyperextension that we're aiming for, about 25 to 30 degrees on that lower angle. And the first thing that we would do is collect cancellous autograft from both shoulders. And we're relatively aggressive in that, we like to collect a good amount of graft. And then we would go on to place intervertebral spacers. And we did this by using a Caspar vertebral distractor. So in the middle image B here, you can see an intraoperative fluoroscopic image that we've taken, lateral projection of the spine. We place most of these under fluoroscopic guidance just to make sure that we're placing them deep enough towards the vertebral canal, designed in such a way that there's a little bit of space before we get to the epidural space of the vertebral canal. But we just want to make sure that they're deep, and as you can see, that they're well seated against the vertebral end plates, which have this sort of sigmoid shape to them, dependent on which you're fusing. So you can see from that alone why a non-patient specific device is less advantageous here. We've got a nice degree of distraction close to the epidural space, and it perfectly conforms to distribute the load. This is the ventral surgical appearance, and you can see that the ventral surface of the adjacent vertebral bodies has also been prepared for the supporting stabilization system. And in image C, you can see in this case, we've used a pair of titanium locking plates, and we'd actually had the opportunity to pre-contour those for the patient as well, which can save a bit of time in the surgery. And then this is packed out with graft. We would put graft in the spaces, obviously, before they were inserted. Following the removal of the Caspar vertebral distractors, I should say, these maintain themselves in position by friction. You can see how, despite the lordotic shape of the vertebral column here, where ventral ejection of the implant would be the main concern, you can see that their conforming nature means that that's much less likely to happen. So just some immediate post-operative CT scans, just to give you an overall idea, an overall image of the instrumentation. You can see here intervertebral spacer and its position relative to the vertebral end plates. And this is a patient that's had bicortical screws placed, locking screws placed, that were enshrouded in bone cement. So the advantage of this technique and surgeon preference here was to use this because they could increase the number of implants. So we've got a couple of monocortical screws as well. And because, of course, it's very simple to apply the bone cement. The disadvantage of this technique is you limit the space that you have to pack graft ventral to the vertebral bodies. And then here, an example of monocortical plate fixation. These have 4 screws per vertebrae. And you can see there's a little bit of metal artifact on some of these images, but you can see there's graft, copious amounts of graft placed ventral to them. And take note as well of the appearance of the vertebral end plate. You have that very clearly delineated hyperattenuation at the immediate post-operative phase. This is the alternative instrumentation, one case that we present in the study, and it's what we're doing most often with our patients now, which is to utilize bicortical screws, but those that integrate into these tulips, they call them, of the pedicle screw system, and how those are connected with rods. And this particular patient has an additional crossbar, and then you can see the amount of bone graft that we're able to the vertebral bodies. So on to some data. Mean age of patients in the study was around 84 months, so very much middle-aged dogs to slightly older. Mean weight being 42 kilos. So in the study, we really were operating on large breed dogs, mixture of some Dobermans, some Great Danes, a couple of Bernese Mountain Dogs, 1 Labrador. Smallest patient that we had in the initial study is this Border Collie, but quite a big dog at 28 kilos. And some patients had 1 level affected, and some patients were found to have 2 levels affected. They either had 2 levels of spinal cord compression, or they had 2 levels of increased signal on MRI within the spinal cord parenchyma at those levels in addition. So that made for a total of 13 operated segments. And here we have the pre-operative textospinal injury score, averaging from 32 to 37, versus the medium-term follow-up, which I'll go on to on the next slide here, with some and I'm sorry for putting in such a horrible and massive table like this to have all the data in it, but I'll just go through the highlights with you. And of course it's in the study, so if there's anything that you want to pick out of it, hopefully it's in there. Hospitalization period was 5 days, ranged from 3 to 7. We had a couple of patients who had a transient thoracic limb lameness post-operative, which we had primarily attributed to the collection of the cancellous autograft, which resolved during hospitalization, but that slightly extended the mean hospitalization period. Median-term follow-up, as I said earlier, was 3 months, and what we saw was a significant improvement in the mean neurologic score, and that was statistically significant. So just looking at the data in general, you can see that we had a mixture of supporting stabilization systems. So we had 3 cases with screw and bone cement, 1 case with the pedicle screws and rod, and the remaining cases were paired locking plates affecting those segments. Here's the individual distraction measurements, and then the distraction index is a percentage of those versus the preoperative imaging. So that just gives you a percentage. Now, what we found was that we didn't completely eliminate subsidence. So we still saw it in some segments. We saw it in a total of 3 of the operated segments. So what we saw in those was that we would have distraction, which was also significant at the post-operative imaging, and we would slowly lose that degree of distraction. But in 3 segments, it went slightly below the preoperative measurement as well. So we have a negative index. However, only 1 of those segments did we consider that to be clinically relevant. And this was a patient who had a mild worsening of neurologic deficits in the post-operative follow-up period. It was not acute or severe. Reoperating was not necessary, so we didn't consider it a major complication. Unfortunately, the long-term outcome of that patient was that it deteriorated. And actually, in the follow-up period, it was diagnosed with immune-mediated polyarthritis, which significantly affected its mobility. And the patient was put on immunosuppressive doses of corticosteroids, and the patient had profound polyuria, and unfortunately urinated in the pet owner's home regularly, and that represented an unacceptable quality of life to all concerned, and the patient was euthanized. So we did have that rather complicated case, unfortunately. That was the one patient that had a poor outcome. The remaining of the other patients improved at long-term follow-up. Also, what you can see here is that minor complications were actually relatively common. So we had a case with fractured bone cement. We had some broken screws or backed out screws in a few cases as well. And one of the pedicle screws had a minor vertebral canal breach. Now, despite those things, we achieved CT determined interbody fusion in all segments bar one. And the reason why we didn't in that one was the surgeon performed a concurrent ventral slot procedure to remove a fragment of annular cartilage that was felt to be necessary to improve the dog's clinical signs. And having that ventral slot meant that we more had a pseudoarthrosis rather than a fusion. But at all segments where a slot was not performed, we achieved fusion. We had several segments that were available for long-term follow-up CT, so greater than 6 months follow-up CT. And we did see adjacent segment pathology at those segments, but in no cases did we have adjacent segment disease. And in the long-term follow-up, the longest of which was 33 months, the patient was improved without any evidence of relapsing clinical signs. Unfortunately, given that we have large breed older dogs, of course, we will see some patients who over a year or a couple of years later develop heart failure or unrelated neoplasia that ends up being the cause for them to be euthanized. So we did lose a couple of patients to those reasons. So here are some of the follow-up scans in the patients with good outcomes. So we can see on the top row here, two-space fusion with supporting stabilization from paired monocortical locking plates. And we can see evidence for CT-determined fusion both through the intervertebral spaces and ventral to the intervertebral discs as well. Again, bit of artifact from the plates, but CT-determined fusion at those levels. And pedicle screw rod, again, we're seeing fusion through across the spacer and ventral as well. Some minor complications associated with the procedures, as I described. This is the patient with the clinically relevant subsidence. So you can see that actually we've achieved a good interbody fusion, but this spacer, as you can see, has integrated itself into the vertebral end plates, and the intervertebral disc now appears relatively narrow. And this is the patient who had the concurrent IMPA. So this wasn't the cause of the dog's perceived poor clinical outcome, and it wasn't euthanized for neurologic deterioration. But nevertheless, we felt there was a less good outcome in this patient relative to the others. As to why I would think that this patient had the subsidence, it might be related to the method of choice for supporting secondary stabilization. This is the patient with the pseudoarthrosis through the slot, and you can see clearly that the center of that spacer lacks any evidence for interbody fusion. This is the patient with the fractured cement. Again, you can see there's fusion despite those findings. Minor vertebral canal breach, and on the bottom row here we've got evidence of screw back out, which again not relevant. We've got ventral fusion here, and we've got a screw breaking here as well. So sort of stepping back and looking at discussion points here. So we had a successful clinical outcome in 8 out of 9 of the cases presented in the study with CT-determined fusion at 12 out of 13 segments. We had, and that was supported by statistical significance in the continuous data that we collected for distraction indices and the neurologic scoring. Minor, apologies for my dog barking. Minor complications were relatively common, and they occurred in 7 out of 9 cases at 7 out of 13 segments, with 4 out of 9 cases having some evidence for adjacent segment pathology. So leading on to thoughts as to how we could potentially avoid that in the future, as I said, we're more often utilising bicortical instrumentation, so maybe there's a role for secondary stabilization there. But the potential negative to that we haven't investigated as to whether or not increasing the stiffness of the construct might in some way affect the adjacent segments to a greater extent, as we believe that fixation strength influences adjacent segment range of motion from the study that we can see on the right here. So just before I finish, I've got a couple of cases. This is a Doberman who was presenting a chronic ambulatory tetraparesis. It's a little bit hard to see in the video here, but there's audible scuffing as the patient walks from both thoracic limbs, and you can see it has a slightly wide and bizarre pelvic limb gait. Was diagnosed with disc-associated cervical spondylomyelopathy at 2 adjacent segments, both C5, 6, and 6, 7. Fortunately, the patient doesn't have any significant changes in parenchymal signal on the MRI, but on the transverse images, there was radial stenosis at both levels of the vertebral canal. So preoperative position, which is what we photograph, so that we have a close understanding of how we should position the patient for the surgery. Preoperative CT scan showing some collapse into vertebral disc, and methods for planning how we go about designing the intervertebral spacer and the secondary supporting stabilization, as I demonstrated to you earlier. Having a 3D print of the vertebrae helps us to prepare for the surgery in other ways. And so, for example, here we can just make sure that our chosen instrumentation fits well alongside both each other and the intervertebral spaces themselves. Just to give you an idea of what that looks like from another view. And then here we have the setup of our OR. So this is our theatre, and we utilize the C-arm to, as I said, assess the depth of insertion of the spacers. A lot of space required for that, of course, quite a large C-arm system that we have. But before the patient's moved into theatre, I make sure we've got the same trough, same towels, and we've got space for the C-arm to be positioned. Patient positioning and hyperextension. And a bit of a grainy out of focus image, apologies for that, but what I'm trying to demonstrate here is the position of a guide to demonstrate how we would drill the holes for the screws, and a drill bit left in situ there, just to show that occasionally it's necessary for a bit of manual distraction of the soft tissues to gain the appropriate insertion angle. This is the application of the vertebral distractor. So I'll just hop back to that. So right-handed Casper vertebral distractor, distraction pins in the vertebral bodies to distract the vertebrae, and fluoroscopic imaging. Most of the time we don't have these towel clamps in the way. Those are a bit annoying in this case, but left them in. Instrumentation at the end, and then that's the immediate post-op imaging to show the size and extent of the intervertebral spacer, its shape and orientation, and how well those conform to the vertebral end plates. This is the morning after surgery, so you can see the patient is independently ambulatory without any noticeable neurologic change, and this is the patient at the medium-term follow-up, who is dragging me down the road, a lot more comfortable and happy to move freely. Long-term follow-up, I've already shown you the image from that case. And then this is a nice video that the owner sent in after a few more weeks to months, just showing you the comfort levels and activity of the patient. So really nice outcome for that dog. And the second video I wanted to show you, just to finish off, is a smaller patient. So this is one of the smaller patients that we've operated on. So this is I think a 19-kilo lurcher who also presented with a chronic progressive disc protrusion causing ambulatory tetraparesis, which sadly had actually been present for quite a while prior to referral to us. So the patient had clinical signs for about 6 months that were progressive. So by the time we examined the dog, as you can see, the severity of paresis in the thoracic limbs particularly was quite severe, and the patient was making mistakes in paw placement more than 50% of the time, very severe audible scuffing and wide, bizarre ataxic movements of the pelvic limbs. Patient had quite significant increased signal within the parenchyma of one of these lesions, representing inflammation, edema, and scarring, or gliosis, we would call that. So we weren't expecting the patient to have a total resolution of clinical signs, because where those changes have been so chronic, we know that some of the electrical cables traveling down the cord are going to be lost. But we were hoping to stabilize and improve clinical signs at least. It was nice to be able to see how we could adapt the system for a smaller dog. So despite having very small vertebrae, we were able to design conforming interbody spaces as well. And we were a little bit concerned about how much space we would have on the ventral surface of the vertebrae. So the team at Fusion very kindly built into the CAD the instrumentation so that we could play with our screw insertion points and so on to help us understand whether and to what extent we would need to pre-contour rods, which I did for this case. That was the appearance of the operating room, just to give you the different angle and how we can keep the C-arm in position so it can slide in and out. And then that's the intraoperative appearance once we've inserted the spacers and we've utilized pedicle screws with rods, the cranial aspect of which I've contoured slightly to get a good position. Sorry to hop around a little bit there. And then here we have the immediate post-operative scan. So in comparison to our in silico planning, really happy there with the positioning of the intervertebral spaces and their relationship to the vertebral end plates. Just a nice 3D recon just to show you what that looks like. And here we have the morning after surgery. So again, just to show you the main advantage of these indirect decompression techniques is not worsening of clinical signs. And then this is our medium-term follow-up with the patient. So very much improved in terms of comfort and really willing to trot down the corridor. Still ataxic and still slightly choppy in the thoracic limb, so that kind of festinating lower motor neuron gait, but much more active according to the owner, much more comfortable and improvement. And I think it's fair to argue that mistakes in paw placement are a bit less frequent as well in comparison to the preoperative imaging. In fact, I would say there was hardly any mistakes in paw placement there. And then lastly, the follow-up image there, so we can see we've achieved interbody fusion in this less than 20 kilo patient as well. It's obviously a little bit harder to get graft, but we've got some evidence for fusion ventral to the intervertebral discs as well. And so that is it for me. That's my presentation. So just some acknowledgements. As I said earlier, the whole team at Fusion Implants, Dan, Ben, Anna, James and Paul, but particularly Victor, who was the PhD student who worked on the design of the implant, especially in its most early stages. But thanks to the team there for their collaboration on this project, as well as the team within Lumley Park Veterinary Specialists, my colleague in the neurology service there, especially Jeremy, who we operate most of these patients together, and Jeremy was integral to the design of the system as well. Andy and Rory from the University of Liverpool, the Smile Teaching Hospital, and of course to Laurent and Simon for having me on today and for giving me the opportunity to present this information to you. So I guess, Simon, if you've got any questions, then it's the time.
Thank you very much, Colin, for this presentation. I wanted to also to inform, I know some people have been asking, that the device itself is not yet commercialized, but it is the intention of Fusion Implants to offer, this device commercially, and they will not only custom made the spacer, but also provide you with all the preoperative planning protocol, the custom surgical guide, the pedicle screw system, and also the putty and bone chips. But in order to be able to have access to this device, you'll be a bit the same as for some other orthopedic device. You will have to go through a training, with a kind of a wet lab course, which is planned for 2024. And obviously, Colin and Jeremy will be running this course. So as soon as we got more information on when it will be available for booking, we'll obviously let you know through the Facebook page. There are a few questions, as you can imagine, starting with the first one from Johnny. What is the CT protocol scan acquisition of the image, especially for small patients where the segmentation of the vertebrae might be a bit more challenging?
Oof, that is a great question. Well, I have to say that fine detail is certainly in the study. I don't have it to hip on the hip at the moment, but yeah. So I'm going to cop out of that question a little bit and say I did put the slice thickness and imaging parameters actually in the study. But I would have to go back and check them because, yeah, obviously we're very fortunate.
No, absolutely, and it will be on this one. Johnny will be all in the paper, which is
absolutely
actually free access. To
it's the open access in Frontiers, yeah. So feel free to open that and check it. But yeah, I mean, obviously the it's not a great challenge. My understanding is to segment the bone from the soft tissues because they have such a contrasting value in terms of that attenuation of CT. So the commercially available software like Mimics can handle that.
Another question from Fernando. In your study, you did not perform distraction on MRI. Do you think the compression response to distraction and without distraction is important to soothe the surgical technique? Also, MRI with dorsal extension and neutral position can help to soothe the surgical technique.
Yeah, it's a good question, and having been to conferences with discussions regarding these surgeries and this disease, a question that often comes up is, what's most important? Is it distraction or stabilization? And unfortunately, I think it's really case specific. And I wouldn't say we had a blanket approach to how we do the MRI. So we certainly don't routinely do traction imaging, and we'll only occasionally perform extension or flexion views. And actually, in the 9 dogs presented in the study, we didn't perform any of those 3 techniques. And it was just because of the fact that it wasn't necessary to demonstrate the extradural cord compression from some element, be it the annular protrusion or the hypertrophy of the facets. So we don't routinely perform those things. Distraction, I suppose what I would say is restoration of normal disc width and normal vertebral canal dimensions and normal neuroforaminal dimensions. That is part of the goal of the surgery. So restoration of something that's normal is important. Now, is that distraction just to that point, or is it then supraphysiologic? I would say getting it to the normal point is probably more important than it being supraphysiologic. And actually, sometimes, if you get to re-image a ventral slot months to years down the line, I mean, we've all seen this. The slot can be totally collapsed, but it's of no clinical relevance to the dog. And I think that's because in those instances, that kind of subsidence occurs very, very slowly. So I think distraction is important for good, immediate, post-operative pain relief and function, but it's not as important for achieving fusion. For that, we want stability. So the quality of the stabilization, the quality of the ability of the intervertebral spacer to resist axial compression is and distribute weight across the force across the end plates is what's important there. So I hope that answers your question. It's a bit of a long one.
And the last question from Emily. Thanks for this great presentation and study, Colin. What was in any neurological deterioration or pain reported in the patient immediately after the traction position for CT?
No. And actually, when I first started performing this type of procedure, I was in my residency training. We perform ventral slots on dogs with cervical spondylomyelopathy, so I have lots of experience of doing direct decompressions in those patients, and some did very well, and some experienced post-operative deterioration. And I have to say, the first time I was resecting the intervertebral disc and distracting, sometimes supraphysiologically in surgery, I really did expect to see that this would have a consequence on neurologic function, and it didn't, and it seldom does. When we're using the Casper vertebral distracting, we're distracting a lot more than we're distracting in CT, because we need the physical space to insert spacer. But I'm pleased to say that typically appears to be of no consequence to the patient.
Very good. Thank you very much for that. We don't have any other question. I think you deserve a big glass of wine to, after a long day and doing, the presentation. But thanks a lot, Colin, for that. And we certainly look forward to Fusion making this, technique and device available to everyone, and certainly, to the wet lab, course to learn the technique with you and Jeremy. But thank you very much, Simon. You got the last word.
Yeah, thanks again, Colin. It's great to have not only the study overview, but your experience in this field. So that's fantastic, giving us a real world overview. So thanks for that. Thanks to Fusion Implants again. And thanks to everyone who tuned in. We will provide a link for this if you want to watch it again, or people who want to watch it, and there will be a podcast as well to go along with it. Stay tuned, or keep your eyes open, I should say, for future webinars coming up towards the end of the year. But that's it from us. Thank you very much.
Bye-bye. Have a good day.